Welcome to The Explainer. If you're joining us today, you're probably already navigating the incredibly complex, sometimes confusing, but absolutely essential world of cancer registry data. Today, I want you to think of yourself as a data detective. Your job isn't just to, collect paperwork. It's to meticulously sift through medical records to determine exactly which cases belong in the National Cancer Institute's SEER registry and which definitely do not. This explainer is your ultimate guide to mastering those SEER reportability rules, and we're going to use clear, structured examples to really lock in your understanding.
Here's our roadmap for today. We're going to cover 1. Case finding versus reporting, 2. The reportability baseline, 3. Malignant and in situ rules, 4. The tricky CNS exceptions, and finally, 5. Decoding ambiguous terminology.
Okay, let's dive right into this with Section 1, Case Finding versus Reporting. So to be a truly successful data detective, you really have to understand the funnel approach. Case finding is the very top of that funnel. It's the process of casting a massive net. You're reviewing pathology reports, surgery logs, admission documents, maybe even pharmacy records to identify all potential cases. But here's the catch. Just because you found a case doesn't mean it automatically goes into the registry. Reportability is the strict filter applied right after that. It defines the exact criteria for the cases that NCI SEER actually requires registries to collect and report. So remember, wide net, strict filter. Moving on to Section 2, the reportability baseline. This right here is the absolute law for our data evidence vault. The term reportable simply means a case meets the strict criteria for inclusion in a registry as established by NCI SEER. If it's on the reportable list, it goes in. If it's an exception, it stays out. Simple, right? Well, the trick is that this list isn't static. It's a living, breathing document. Let's see how this builds chronologically. The baseline reporting start date for SEER registries is January 1st, 1973. But as you know, the medical field evolves, and so do the rules. For instance, notice the updates that took effect on January 1st, 2023. High-grade astrocytoma with pyloid features, or HGAPAP, became reportable, and so did mesothelioma in situ. And looking ahead to cases diagnosed on or after January 1st, 2025, post-transplant lymphoproliferative disorder, or PTLD 997-1, actually becomes reportable as a 3 behavior code. So, as a data detective, you always have to be aware of the diagnosis here because the rules literally shift beneath your feet.
All right, Section 3, malignant and in situ rules.
Generally speaking, you're going to report all histologies with a behavior code of /2, which is in situ, or /3, which is invasive, according to the ICD-0 3.2. But you really need to consider these specific, frequently questioned diagnoses that NCI SEER explicitly includes. Mature teratoma of the testes in adults? Yep, that's malignant and reportable as 9080/3. What about a non-invasive mucinous cystic neoplasm, or MCN, of the pancreas with high-grade dysplasia? Yes, absolutely reportable. And urine cytology positive for malignancy? That one is reportable for diagnoses from 2013 forward, and you code it to the primary site C689 if you don't have any other info. So the crucial point here is knowing exactly when to stop. Just because a behavior code might technically align, well, that doesn't mean it magically bypasses the exceptions list. As a detective, you must drop the case if it falls into these specific buckets. Do not report skin primaries. That's topography codes C440 through C449 with histologies like basal cell or squamous cell carcinoma. Do not report in situ carcinoma of the cervix, or CIN3. Prostatic intraepithelial neoplasia like PIN2 and PIN3. Actually, collection stopped for those way back in 2001. And you can go ahead and skip colon atypical hyperplasia as well. Recognizing these exceptions is what saves registries from being completely flooded with non-reportable data. Which brings us to Section 4, the CNS exceptions. Okay, so I literally just told you that reportability generally requires a behavior code of /2 or /3, but for primary intracranial and central nervous system tumors, we totally throw that rule out the window. Benign and borderline CNS tumors with behavior codes of /0 or /1 are reportable, and this massive exception has actually been in place since 2004. And this brilliantly illustrates exactly where this exception applies. Let's start with the meninges. To use the 0 or 1 exception, you have to match specific ICD-03 topography codes. If the tumor is in the cerebral meninges, that's C70. Spinal meninges is C71, and meninges not otherwise specified is C79. If your benign tumor falls into these exact topography codes, it enters the registry. The exact same logic applies to the spinal cord and cranial nerves. The required topography codes here span from C72 right up to C72-9. This covers the spinal cord, the olfactory nerve, the optic nerve, the acoustic nerve, and so on. Notice a pattern here? It's highly, highly specific. Just as a quick side note, benign tumors of the peripheral nerves, which are your C47 codes, those are not reportable. It absolutely has to be the central nervous system.
But wait, topography isn't the only trap here. Terminology is just as important. For intracranial and CNS cases, the specific words the doctor uses dictate reportability. The terms neoplasm and tumor are reportable because they're actually listed in the ICD-0 3.2 with behavior codes of 0 and 1. But what if the scan just says mass or lesion? Well, those are not reportable terms. They just don't have those behavior codes attached in the manual. Words really, really matter in data detection.
Let's tackle Section 5, Decoding Ambiguous Terminology. So what happens when the medical record just isn't perfectly clear? Let's look at some real-world case scenarios. Here's your very first piece of evidence. The pathology report reads, prostate biopsy with markedly abnormal cells that are typical of adenocarcinoma. Do you accession this case into the registry? Take a quick second to think about it. And the verdict is reportable. You accession the case. Why? Because the phrase typical of is officially on the SEER Ambiguous Terms for Reportability list. If an approved ambiguous term precedes a word that is synonymous with a reportable tumor, like adenocarcinoma in this case, it crosses the threshold and goes right into the registry. Let's try another one. You pull an outpatient report, and the final diagnosis simply reads, rule out pancreatic cancer. Does this one make the cut? The verdict here? Do not accession. Rule out is really just a directive for clinical workflow. It isn't diagnostic. Since it's not on the approved ambiguous terminology list, it fails our strict reportability filter. Drop it. Now let's look at a discrepancy because, let's be honest, medical records frequently contradict each other. An abdominal CT states there is a mass highly suspicious for renal cell carcinoma, but a subsequent biopsy comes back saying neoplasm suggestive of oncocytoma. A malignant neoplasm cannot be excluded. What on earth do you do when the imaging is highly suspicious, but the biopsy is just wishy-washy? Now, what's really interesting about this is establishing the hierarchy of truth. The verdict is do not accession. The suspicious CT finding prompted a biopsy, right? But that biopsy did not actually prove the mass was malignant. Furthermore, the term suggestive of on the biopsy report, that's not on the SEER Reportable ambiguous term list. The biopsy essentially proved that the suspicious scan wasn't definitively reportable. You've got to drop the case. When you hit these roadblocks, you need a reliable workflow. Step 1, always look for a clear statement of malignancy from the physician in the record. If you have that, you don't even need the lists. Step 2, if the wording is ambiguous, check the official ambiguous terminology list to see if the phrase, something like consistent with or probable, makes it reportable. But remember, the Commission on Cancer explicitly states these lists are references of last resort, which leads us to Step 3, follow back. The absolute ideal way to solve an ambiguous case is simply to contact the physician who diagnosed or staged the tumor. Before we wrap up today, let's lock in these crucial rules from the guidelines. Never, ever accession a case based only on suspicious cytology. You strongly need to follow back on cytology using ambiguous terms. However, if a reportable diagnosis is confirmed later on, you actually go back and use the date of that initial suspicious cytology as your date of diagnosis. And finally, I'll repeat it because it truly is the golden rule. The diagnosing physician is always your foremost resource. We're dealing with data, yes, but that data represents human lives diagnosed by human doctors. Which leaves us with this final thought. We've seen how specific words, rolling dates, and complex exceptions dictate the exact shape of our national cancer data. As diagnostic techniques advance and medical vocabulary itself continues to evolve, how will this delicate balance between casting a wide case-finding net and applying those strict reportability filters change the future of cancer research? The registry is truly only as good as the data detectives curating it. So keep learning, keep questioning, and keep applying those filters with precision. Thank you so much for joining me on this explainer.